Hello, and welcome to another edition of AOA's Lessons in Orthopedic Leadership. This episode is being hosted by myself, Dr. Alexander Aleem, and I am thrilled to have Dr. Danny Goel join us. For those of you that don't know Dr. Goel, he is a practicing surgeon and surgical educator in Vancouver, currently serving as faculty at the University of British Columbia in the Department of Orthopedic Surgery. He received his medical degree from the University of Manitoba and then pursued orthopedic training at the University of Calgary before completing fellowship training in shoulder surgery at University of Western Ontario and Harvard. Relevant to this, Dr. Goel is also the Chief Executive Officer of PrecisionOS, one of the leading virtual reality surgical training programs, and PrecisionOS has been grateful enough to sponsor a couple lunch and learns at the upcoming AOA annual meeting for both the Residency Leadership Forum as well as the Cord Program Directors Lunch, so please be sure to check those out. We're going to be spending the next episode here talking about the role of virtual reality training and surgical simulation, especially in orthopedics residency. Danny, it's really exciting to have you. Thanks for joining us.
Alex, it's a pleasure to be here. Thank you.
So let's just kind of start out. What got you interested in this? Why did we kind of look at VR as a tool for surgical simulation? You and I both trained in very hands-on training, clinical experience, cadaver labs, et cetera. So how long is this, and kind of why the pivot to virtual reality?
It's a really good question. And when I was reflecting on a lot of this over the last several years, there's simulation that we did at home and probably didn't call it simulation. And so when I was reflecting on my residency, when I was a resident in Calgary, I brought home a knot pusher, I brought home sutures, and just like we all probably did, or most of us did, and I was actually doing that at home. And the most appealing part of that was that I had access on demand. And you fast forward to today, and like you said, we all use cadavers and the other simulators that are in sim centers, et cetera. But the challenge with simulation has always been access. And so really, I've been thinking about this as a resident because I knew that if I could practice before I went to the OR and my attending handed me the knife or the scope, that was my one chance to keep it. And if I lost it, and we all know this feeling is when you get that instrument taken away from you, you're climbing the hill again to get back to that point. So I wanted to maximize that chance, and I wanted to use whatever means necessary to get there and have that opportunity.
That is so relevant because I remember sitting in my own living room during residency and throwing knots and trying to kind of do that kind of simulation. And I think we've all felt that, this is my one chance, don't mess this up. And then you
That's
fumble
right.
and you're
Yeah.
trying to get back to it.
Yeah.
So virtual reality, obviously you mentioned access is one of the big
Hmm.
things with that, on-demand access. What have been maybe some of the kind of driving forces to that access? On the flip side, some of the challenges that you've had with that access as we've kind of tried to expand VR training and surgical training.
The challenges of all, I'll highlight the residency challenges that we've seen evolve over time. Obviously, when you and I trained, things were somewhat different in the amount of time we spent clinically over the years. That number has declined, and that's been mandated, as we know, across Europe and North America. So that's one fundamental change that's happened. COVID obviously has really impacted how we think about things because when we lost all that access to not only simulation but practice, there's been a skill decline in the residents
Mhm.
that were impacted that year. And then, of course, how do we get those residents back up? Are they still being impacted? Or are they impacted now? And what does that mean for them in the future? Now, when we think of the simulation in itself and what the challenges have been with this, is that we're so accustomed to having something in our hand that we have to touch and feel. And that's one part of learning. The other part of learning is all the decision making we do. And if I break down the operative experience, and I remember this case vividly, when I was teaching one of the residents in the OR about an ankle fracture, the resident was doing the Weberby ankle fracture and he couldn't see what he was doing. So what I did is I took an Army Navy and I put it in the wound so we had more visualization of what he was doing, thinking that I was actually helping him. But in fact, what I did is I disabled his thinking and that I didn't allow him to realize that he couldn't see and how to make a
Mhm.
decision to increase visibility. So when we break down surgical experience in the OR, it's limited to both critical and non-critical steps. And then I've
Right.
asked my colleagues to say, how much of the non-critical parts of the case are you letting the resident do? And how much of the critical parts of the case are you letting the resident do? And then let's go back to virtual reality and say, what does that technology allow us to do that actually allows the resident to make decisions, during both critical and non-critical cases that we can then collect data on and then evaluate their performance.
I think that's such an interesting part of it, because I think in my own shoes as a program director, the residents focus on the steps of the surgery and being very kind of rote memorization, but they're not really thinking about those other sort of critical decisions. Like you said, I think it's a great example of just retractor placement, or what is the one thing that I'm doing here that oftentimes we as the attendings are sort of doing subconsciously, because we're seeing that and taking that, like you said, that decision out of the resident's hands almost. So how does VR help with that? Because I think some of the concerns that people would say would be, all right, well, VR, very much could just be rote memorization of a surgical step of a surgery. I am nail of the femur, for example. Starting point, put it here, put your entry room, blah, blah, blah. So how can VR help with maybe some of those sort of
Yeah.
non-anticipated decisions that you're highlighting?
It's a really excellent point. And that's one of the things that we tried to focus on early on, is to focus on the principles of surgery. So if I was to use a femoral nail as an example, the simulation that tells you where to put the guide pin isn't really a simulation. The simulation that is allowing you to decide where to put that guide pin and measuring that is actually much more of a simulation that's of value to the end user. So for a femoral nail, yes, it's step 1, step 2, and step 3, which, as you mentioned, is actually dangerous, because then you become mindless in what you're actually doing. Where the value of VR is, if we can allow the residents to go into that same femoral nail module, decide where they're going to put the guide pin on the greater trochanter, where they're going to put the femoral neck and head screw, and how deep they're going to go into the neck. That's the part of surgery that becomes really powerful in VR to translate that skill into the operating room.
And so for those of the listeners that may not necessarily be familiar with the platform, this allows residents to make mistakes.
Correct.
Supposedly. So, and then what's you mentioned the data to sort of assess competency. What's the data that the residents are getting, or what's the data that maybe faculty are getting to then be able to help guide some of that competency training?
Right. So we've mapped all of the content that we've built against the ACGME milestones. So for example, if you do a femoral nail, we've mapped it to the ACGME requirement for that femoral nail and made a suggestion for this level of competency. And again, I use the term suggestion because it's really important that, Dr. Aleem validates that milestone in the operating room. We don't want to make that claim that we're validating this as the achievement of that milestone. So we make these suggestions, and that data goes not only to the program director, but also to the faculty. And then the resident gets her or his own report to state, and actually they can actually see which ACGME milestones they've hit, which procedures they've done, and how they're tracking relative to their peers.
That sounds really powerful. One of the things that's kind of come up in this has been, Access One, time management being another part. If you really jump into this could be something that you spend endless hours on. We all know we have limited time in the day. How do you see this as becoming a required implementation, or what have been some of the strategies that you've seen to really help with programs implementing this? And maybe a follow-up, is this maybe more of a entry-level thing for the junior residents that then they potentially need less of as their senior, or do you see this potentially being something that you can kind of graduate through the entire training program and even beyond training program?
Yeah, a lot of great questions there, Alex, and I'll address each of them. From an access perspective, it's one thing that we've known to be of extreme value is if the first and second year residents have their own headsets.
Yeah.
The hardware is so inexpensive right now. I mean, it's 1/6 the price of an iPhone. So I mean,
Wow.
they're $200 to buy, the Meta Quest 2, which is one of the headsets we use to provide the software. So that's one part. I think when the interns have their own hardware, it's an access issue. They don't have to travel to go anywhere else or to have access to the simulation of any type. Number two, time management's a really interesting phenomenon. And, I've read this book recently called Deep Work. And what that focuses on is, in a very distracted world, how do we do work in a focused manner? And what virtual reality does, it's actually learning in a non-distracted environment.
Right.
And so when you're looking at the femoral nail and you're doing the femoral nail, that's the only thing you can do. You can't text, you can't talk to your friends, you can't watch TV. I mean, all the things that we know are distracting in today's world. So by virtue of having non-distracted learning, the literature has shown that you can actually learn more in less time than you would practicing in the real world.
Right.
So And so, some of the earlier studies that were done show that you can actually learn in 8 minutes what would traditionally take you 30 minutes or things like that. Because
That's
again, it's
yeah,
focused learning.
yeah.
We've taken several strategies to help integrate the software into the programs. And, we're reaching close to 100 programs now, from residencies all the way to some fellowships now, obviously with our partnership with ASES, is we've done the following. Number one is we recommend that all the interns have their own hardware. That's number one. Number two is we've created a curriculum, because without a curriculum, it's sort of, you're using an instrument without a music sheet. And so we
Right.
need to have a very specific way to implement this software. So that's number two. The third thing we've done is we've actually created a VR bootcamp that we've mapped to the ABOS PGY1 skills. So and that's something that all the residents and the entire country are going to do starting in, 3 months. So now you know which module to do for which milestone or for which application under the VR bootcamp. So those strategies are a few of the ways that we've empowered organizations to implement and integrate the solution. Because historically, as you know, simulation has not been used on a regular recurring basis. So how do we change that paradigm of where we get more accustomed to practicing before we perform?
I think that's a great sort of lead up to the next question of practicing versus performing. And Van Heest, who's our outgoing president, she always, one of the things I always remember her saying, the OR is not for practice, it's for performance. And
That's
I
right.
think that's a message that we have to kind of get across.
Yeah.
And a lot of, I think, the resistance sometimes that I've run into, at least when talking to my own residents about it, is, well, this isn't the same as a clinical experience or doing the surgery. And of course it's not. But how can you help frame that as the more you practice, the better performance, and then potentially you're going to actually have a better experience in the OR because you are not going to give up the knife after you make one mistake because you've understand all that kind of stuff. I know you've got some data that's coming out, but what has been sort of the most powerful maybe studies that you've been able to show, or maybe some of the more powerful arguments you've been able to kind of convince this paradigm shift to happen? Because I think that's one of the biggest things that we're seeing is there's a novelty to it, but then how
Yeah.
do you make it a part of your daily practice and to improve your skills throughout your training?
So I'll talk about the idea of competency, because I think this is really
Yes.
important, and it
Yeah.
highlights the challenges we have as an industry in general. Number one is we should look at competency in three different ways. And I think a few of them we do very, very well. So performance evaluation of an individual in the clinic is a really good and common thing that we do. Dr. Aleem, I saw your patient. This is their exam. This is my interpretation of their MRI. This is what my plan is. That's a really good way for you to evaluate my performance. The second thing we do really, really well is knowledge evaluation.
Hmm.
Things like OITE, any board test, those things are really, really powerful. Any multiple choice exam you do, or if you're standing in front of an X-ray and you quiz me on a particular problem, those knowledge tests are really powerful. So we would do a really good job of assessing competency there. The one gap I think we have really is any skill-based assessment that's objective. If I'm in your OR and I tie a knot, or I put the anchor in the wrong place or the guide pin in the wrong place, you just know I did that, but you don't know by how much,
Right.
right? And you won't give me the time to adjust to that error that I may have made. So how do we bring that lens into implementing a solution that helps us now objectify and assess people with data on that skill-based assessment before they get to the OR? And, one of the ways that we've talked to a lot of the programs about implementing this and thinking about this is you may allow your residents a lot of OR time when they first start, but what exactly are they doing? And are they just teaching themselves bad habits and reinforcing things? That's something to consider. But I think the other part is we can't add more time to their schedule. So we need to
Right.
maximize their time in the OR. And wouldn't it be great if we can use a tool like VR to enable them to do more early on? So by the time they're in their fifth year, they're really operating at the highest level possible before they graduate.
Do you see that as being a number of cases, or truly being kind of that competency you mentioned that you're able to sort of map and suggest the milestones, from a program director standpoint, getting that dashboard? Could you sort of say and set some, I think that's kind of the next step is
Yeah.
set those minimum expectations and say, okay, if you've reached this level on these cases, we expect you to be at this level on the clinical side. Can we then kind of marry those together? Is that kind of how you see this
That's how I
coming
see it
through?
coming together. Yeah,
Yeah.
exactly. And that's sort of our reason to map the ACGME milestones with the
Right.
simulation, so you can actually make better decisions about when to allow the resident to do what part of the case.
I love this because I totally agree. And I think the skills assessment and the competency assessment is really an important part of it. And as I've become 3 years into a program director, that's really the area that I think, as you mentioned, we struggle with the most.
Yeah.
Obviously, the ABOS has now a new initiative that's going to be starting required for all programs in 2025 with the KSBs,
Hmm.
specific skills evaluations. You've got this VR that's kind of mapping with those milestones, skills mapping with the milestones. Do you see this as kind of the perfect inflection point of really being able to leverage maybe where we're trying to go as a society and this technology?
I think the ABOS has really nailed it when it comes to how we assess competency, because they've basically done the knowledge, skills, and behavior piece, which I just sort of talked about in the last part. And that is what we're doing right now, as well as we're mapping the content with the skills-based part of
Right.
KSB as part of ABOS. So I see it all intermingling together. And with the ability to add data to people's decision making and performance, I think that's something just we've never seen before.
Right.
And so introducing it is a little bit foreign and strange, because listen, we've been practicing on cadavers, and we've been practicing on these other models like sawbones, but we just don't get that. Yeah, it may provide you haptic feedback, but it's not actually providing you data on whether that's the right thing to do in the OR when you're actually there.
I think that's such a great point about this too, because I think the haptic feedback is maybe, as you mentioned at the beginning, a little point of concern that some trainees have. It's not the same as holding a saw in your hands, but the data on the dashboard that you get is to within the millimeters of how far off you might be with a guide pin or what your tip to apex distance might be using that femoral nail. I think one of the other parts of it is end user experience is having some sort of expert being able to also help guide that, because you can get a data report as a resident and get all these things.
Hmm.
How does a program director, how does a surgical faculty, how does an expert then maybe kind of come in? And is that something that also really needs to happen for this to be successful?
Yeah, there's a couple points I wanted to mention, Alex, which you mentioned before about haptics. So haptics are a really interesting topic, and then I'll get to the mentorship piece as
Yeah.
well. So haptics in VR, we do offer feedback when you're, say, drilling or sawing bone.
Right.
Because as we know, there's three things that happen when we do that. One is when you drill, the bone changes, you put a hole in the bone. Number two is the sound of the drill changes, pitch changing from cortical to cancellous bone. So we
Right.
modify the sound. And the third thing that happens in the controllers that we have is you can increase or decrease the vibration that occurs. And the question that I don't know the answer to is, how much of that combined sensory feedback do you need to
Right.
transfer skill to the OR? So far, all the studies that have been done using our software, where they compared practicing on a cadaver, a virtual simulator, a sawbone, has shown that there's been actually no difference in skill transfer into an actual cadaver. And
Wow.
so,
Okay.
so it highlights those studies. And those were done. Bill Levine did that cadaver study versus VR at Columbia. The authors at HSS and Lenox Hill did it, comparing it to a physical arthroscopy simulator. And
Hmm.
then Queens just published a paper, or is in submission right now. So my understanding is comparing non-surgeons, teaching them arthroscopy in our system, comparing it to an actual physical simulator, and then testing them on a cadaver.
Hmm.
So that's the third part, or the second part of your previous question. The part that you ask about having mentors, I think, is extremely important. There's two types of way we learn. We can have an asynchronous experience where we learn on
Hmm.
our own, or we can have an actual synchronous experience with a mentor. There's nothing more valuable than learning from a mentor, because otherwise then I'm teaching myself surgery or what I
Right.
think is the right thing to do.
Right.
So there's two ways a mentor can participate in this software. Generally, is you can join in VR, where you can be present as a digital version of yourself, or you can actually participate from your cell phone or your computer. So you don't actually need to be physically or virtually present in the operating room to provide that mentorship, which I think is powerful. And it can be done either live or on demand at a later time. So a lot of these strategies to implement the software, you can see, is we've had a lot of feedback, a lot of positive and negative comments about what we can do and what we shouldn't do and what we should do to help implement and integrate this. Because if we can successfully implement this the way we've seen some of the programs launching it, it'll be a complete foundational change to how we train residents,
Absolutely.
right?
Yeah. I think
Yeah,
this is such an exciting area, and it
yeah,
gets those of us that are in surgical education so amped
yeah,
up. You've been part of this journey for a long time now, and you've seen kind
Yeah.
of the evolution of this. What's been sort of the most exciting aspect of kind of the Precision OS journey for you,
Yeah.
kind of building this from the ground up? You've mentioned over 100 programs now, partnership with the ASES. I mean, the continued influence and continued expansion throughout. But what's been kind of the most exciting part for you?
So there's been two parts. Number one is this certainly feels like it's something bigger than I am, right?
Yeah.
Where, to be able to impact skill in a way that we just have never seen before from here to Asia and to Europe is so profound for me that that's been the reason why I keep going, because it's so profound that way. One of the other things that's happened is this is a really interesting marriage between tech and medicine.
Hmm.
And, the exciting part for me is to work with some of the smartest engineers, and they ask me questions that frankly I never thought about as a surgeon, you know. And honestly, I had to go back and actually go back to the OR and think about the question they asked me so I could actually have a good answer for them.
That's awesome.
And one of the things that they asked me was, when you're operating, do you actually feel the instruments in your hand? And so when I went back and did my, one of the shoulder cases a couple of years ago, because they asked me what it felt like to hold a scope and a burr at the
Right.
same time, you actually disassociate from the OR depending on your experience level. You stop paying attention to the weight of the product in your hand, and you're so in tune with the visual feedback you're getting. So next time you're doing a rotator cuff repair,
Yeah.
Alex, pay attention to that, because I actually didn't feel, or I couldn't recall feeling the scope or the burr in my hand because I was so visually oriented.
Right.
And so it challenges the idea that we need to have some type of weightedness in our hand to transfer skill to the OR, right? I mean, just
That's
a remarkable question that I never thought
that
of
that is
before.
I love that because I'm thinking the
Yeah,
last rotator cuff repair I did, I couldn't tell you how much the scope weighed or
yeah,
how
yeah,
much the needle passer weighed, anything like
right,
that.
yeah,
That is such a I love that. So we're coming up kind of towards the end
yeah,
here. So I think you and I have talked offline about this. We're not even close to being tapped into VR
no,
tech. I mean, we're scratching the surface on what can be done. What sort of, what's going to be the next big thing that you maybe see here with VR? There's been a lot of this expansion with simulation training.
yeah,
I think the interactivity for me is one of the things that I've really kind of found very powerful. Like you said, the ability to kind of reach all four corners of the world
yeah.
and do it from your living room. But what's kind of the thing that may be kind of the next disruptive thing we can see with this technology?
So I think that artificial intelligence is going to play a role
Yeah.
in this in some form or another. The other part is, as you mentioned, is mentorship. Teaching in a way that we've never taught before is part of this opportunity. And then the third part is, we're going to have access to a really large amount of data on how people are performing. So
Yeah.
this could open the door for us to say, hey, listen, you medical student, we're thinking about doing a non-surgical specialty. Have you considered doing something surgical? Because your decision making and your 3D spatial awareness is actually some of the best we've seen when we compare it to hundreds of thousands of people that have done this particular skill.
Yeah.
And it's sort of like how Kobe Bryant was discovered in some park in LA. We don't have that in medicine right now. And I don't know about you, but for me, nobody ever asked me how my technical skills were, nor did I have an assessment. I
Right.
just, I guess I assumed people thought I was a nice guy and I had decent grades. So I got into orthopedics,
Exactly.
right? But imagine being able to assess people before they actually even start, and empowering those that maybe should have a career in orthopedics, and then empowering those who are kind of on the fence about whether or not this is a specialty for them. So I think, the sky's the limit with the technology. And like you said, we haven't even scratched the surface with it.
It's so amazing, and I always get so much more inspired every time I talk to you about this kind of stuff. And I'm looking forward to sort of seeing where Precision OS takes us. So, Danny, that was awesome. Thanks for taking the time. And again, big plug for the AOA annual meeting in my hometown, St. Louis, Missouri, coming up at the end of June. I'll have a couple lunch and learns with the Precision OS team, and look forward to catching up with you there.
Looking forward to it. Thanks, Alex.
All right, thank you again.